How is it that the wealthiest country in the world has such a screwed up healthcare system? After 35 years in the healthcare industry, I decided to retire and share my secrets with you. I'm Chuck Melendi, and this is Disruptive Dialogue. Hello, Disruptors. Chuck Melendi with Disruptive Dialogue, where we bring you the information that you need to be an informed consumer of U.S. healthcare, as well as providing insights to what's hurting our healthcare system and how we can make it better. For those of you joining me on YouTube, you're going to notice a slight change in costume as well as background for both me and my guest. We had some IT glitches on our initial recording, so we had to re-record a portion of this podcast. So sorry about that, but hey, not all is smooth in podcast land. Well, today is really special. I kind of called today's episode What Patients and Docs Don't Know About Insurance. As a precursor to today's show, I'll tell you that it's not often that we get to hear from an executive that's worked in the C-suite for both an insurance carrier and a large health hospital system. Our guest today is going to share with you what it was like working for these healthcare companies as a doctor and the dilemmas that he faced when decisions were made with a focus on finances and not on patient care, which went against his training and his ethical code as a physician and ultimately led to him leaving the industry to try and change it for the better. Our guest today is Dr. Seth Glickman. Dr. Glickman is a former insurance and health system senior exec. He's held positions as the chief medical officer at Intermountain Health in Utah, as well as Blue Shield of California. Dr. Glickman has seen the U.S. healthcare system from the inside, and he left well-paying jobs to try and help our healthcare system today. He is now a researcher and an advocate for reform in the healthcare finance space. He does coaching for executives and physicians. And with that, I would like to welcome Dr. Glickman to the show. Seth, welcome to the show.
Thank you, Chuck. It's great to be here.
Now, you have your own consulting business. What's that called?
Seth Glickman Advisors. So it's an original name, but
yeah, very catchy.
Thank you. It took me. It took a marketing consultant to come up with that. So
very nice. And what exactly do you do with that business?
I do a couple things. One is advisory work for healthcare leaders and healthcare organizations to really focus on making our healthcare system better. And a lot of that work is focused on improving access and affordability. And then I also work with individual leaders in an executive coaching capacity to increase the leadership strength of doctors to be able to make positive change.
So thank you, because it's a sacrifice to leave big systems, making a nice paycheck, doing probably you're pretty good at what you were doing and getting into a groove and you stepped away.
Yeah, it's a sacrifice in some respects, but incredibly rewarding in many others. And ultimately, that's why I decided to focus on what I'm doing, because I want to make a positive impact and help people navigate the healthcare system better and make it work better for them. So that's what fills my cup, and that's how I want to spend the rest of my career.
I love it. You get to a certain point in your life where you're like, you know what, I just want to make a difference and help people. And so I'm very curious about this. But when you were an executive, not just at Blues of California, but also at Intermountain Health, because I haven't really talked about hospital systems yet, and I'm going to. What was it like to be an executive there and be a physician and seeing business strategies and directives coming down that were more focused, I would imagine, on the bottom line than on patients? How was that?
It was surreal, and it's very easy to feel like a fish out of water when you have the DNA of a clinician and you focus your whole career on how do you help improve people's overall health and well-being, and then you obviously encounter the realities of the business of healthcare, and it's there's a reason it's become such a big part of our economy. It's a huge business, and so I think a lot of my work and a lot of my career has been focused on how do you create synergy and harmony between those two aspects, because I think there are ways to align purpose and also continue to see healthcare thrive as a profession and industry.
I don't have a problem with people making money or organizations making money. But what we are seeing is that huge amounts of money are being made. And if the product is supposed to be about taking care of people, study after study is showing that access to care and outcomes of care, well, let's say both those are going down and costs are going up. And usually somebody gets fired for that. But what I see when I open the pages is CEOs making $20+ million a year. I see organizations hiding profits. I see them buying up competition, and I see premiums going up. They just said employers should expect their cost to go up for health insurance benefits next year 15 to 18%. Mind-boggling.
It's crazy. We're going to see big premium increases not only with employers, but unfortunately, a lot of people are going to be facing either losing their health insurance altogether or having to basically pay big premium increases. And it really is having a toll on everybody. And I think it's one of the things that really got me interested in trying to improve healthcare, because I think one of the things that is most fundamentally broken is there's plenty of money to go around, but we're not paying for the right types of outcomes or creating the right incentives. And the most fundamental thing that's broken is we pay for people to get sick and to take care of them when they're sick. And we should be focusing on how to keep them well and provide the care they need to stay healthy and out of the hospital and be able to spend time at home with their families. And unfortunately, there are so many incentives that actually promote the opposite.
Yeah, and we're going to get into that. For me, like, you were a chief medical officer. So, thank goodness they had a doctor that was the CMO. I find that in the highest levels of leadership, both of the carriers and of hospitals in particular, there should be more physician involvement. If, everything I see, I look at board of directors, I look at CEOs, most of these are finance people. They're not healthcare professionals. I've looked at a couple local hospitals. The number of physicians and nurses on their board is not near as many as you would think, when those are the people that should be helping the organization drive what their mission is. And I challenge people when they say, well, corporations should be allowed to make money. Healthcare is different. If someone's gouging you with a really cool TV or a really cool car or a really cool bike, I don't have to buy it if I don't want to buy it. But if I have a heart attack, I don't have a choice. If you get sick, you don't have a choice. And so we are captured consumers in a market that to what I see is the decision makers at the highest level are creating a commodity market, and it's abhorrent.
Yeah, there's no question that having stronger clinical leadership at the table when decisions are being made, when organizations are creating their strategy for how they're going to deploy the capital that they have and how they're going to take care of people and fulfill their mission is critically important. And I think there's a certain ethos about clinicians in terms of the reason we go into medicine and how we're trained, and we take the Hippocratic Oath, and we really try and focus our life's work on healing and making people better. And I think it's really important to have that lived experience inside the C-suite when important decisions are being made. And I think it's training and empowering them to be effective leaders, because you could be one of the best, most specialized people in the world in your particular area of medicine, and you can be a terrible leader and someone who doesn't know how to navigate politics or deal effectively with conflict, or how do you influence, when you don't have positional authority. And those are challenges for a lot of clinical leaders. And, it's an area that I'm focused on more in my career.
Yeah, absolutely, and we're going to touch on that. Well, I can tell you, as a guy that has called on physicians, I don't anymore, but he used to. I would not tell any physicians they weren't a good leader. The furthest I would go with that stretch is I would say you weren't trained to do that. You weren't trained to be a business executive or a lobbyist. You were trained to take care of patients, and unfortunately, the environment is making y'all. Did you have a specific moment where you were like, what am I doing? Or was it just a gradual thing that you said over time, this isn't what I signed up for and I need to get out and fix this?
Yeah, I think it was more of the latter. But I think as I look at the trajectory of my career, a lot of the early part of my career was really about gaining experience, because it's really hard to understand how our healthcare system works or how it doesn't work unless you're actually on the inside. Over time, what I felt was that increasingly the things that I was being exposed to and the things that I was required to do as part of my duties and responsibilities in those increasingly senior roles conflicted with my underlying core values and value structure. And over time, my values have been pretty consistent, but as I learned more about the inner workings of healthcare, that conflict really became more apparent and more concerning for me, and that sort of led to a lot of what I'm doing now.
That's awesome. I've got a follow-up question for you later on that one, but I want to jump in. You said that you described health insurance as having a hidden curriculum. What insiders know, but patients and even most doctors don't or aren't taught. Can you expand on what you mean by that?
It's very clear what their mandate is. It's to generate profits and increase returns to shareholders. And so everything they do is focused on that sole objective. And on the flip side of the coin is all of the people that actually need to consume and receive healthcare, and having to navigate an ecosystem where the ultimate goal is not really aligned with what patients need for themselves and for their families. So I think that's kind of at the root of a lot of these issues, and they're growing very, very large, very, very powerful, and essentially what we call vertically integrating. They're becoming not only payers but providers. And so I think those are at a lot of the sort of underlying issues about this kind of hidden or maybe not so hidden agenda.
Yeah, I think that fortunately, a lot of us, ourselves included, are starting to expose that and are starting to let people know. I work with employers and I tell them the fiduciary duty to a payer or a PBM is their shareholder, not you. I have a question for you, and I'm not sure that we did this in the pre-call, and you can answer it if you want. Were you ever in a room where you literally heard someone in the C-suite basically push back on patient care and basically say, we can't do that. We've got to hit this number. So no, we're not going to hire 10 more nurses, or we're not going to get a new MRI machine, or we're not going to whatever. Were you either at a health system or at a carrier, were you privy to the conversations that kind of went like that?
Yeah, it was fairly common, I think,
Okay.
and I would say that the organizations I worked for, I think I vetted as best I could, but the tension that I would feel between um, the organization's finances and the care we were delivering was apparent all the time. And I would say that, by and large, even though I saw a lot of examples of what you describe, I think by and large, the people that I worked with were operating with good intent. Healthcare is a very challenging industry. I think what I saw more of is also not not enough of having the clinical or patient perspective in the room, or having that be a more important part of the conversation. And so I think sometimes those are acts of omission where it's much more convenient to talk about financial outcomes. I think a lot of it is people not understanding and having walked in the shoes of either providing care and trying to navigate our system, or very often what I would see with some of my business peers is they would sort of change their tune a bit when they were personally affected either by illness, or someone in their family was trying to navigate the system and was completely frustrated, and they would come to me as the medical expert and say, hey, I need help, can you help me do X, Y, and Z? And invariably, I think those experiences change us and help us grow as leaders. But yeah, I hope that answered
No.
answered your question.
No, well, you said it happens all the time. I'm like, that's what I thought, but okay,
Yeah,
thanks for
yeah,
confirming. Well, I think legislators are getting more educated. I also think that they are starting to experience that a little bit more. And that being said, you wrote a really cool op-ed not long ago, had like these little devils and illustrations. I loved it. Um, Give us a little example. I think it nails exactly what you just said about getting to experience the system yourself.
yeah. I went through this experience where I'm over the age of 50 now. I'm 51, and so things start happening as part of the aging process. And long story short, I discovered through some testing I had done with my physician that I had a lesion or a small mass on my pancreas. And I went to see a specialist who recommended that I get a special MRI study, which is really designed to really evaluate that type of thing. And it was very, very challenging and cumbersome to actually obtain the authorization needed to actually get that test. And it actually created delays in my care and my diagnosis. And fortunately, I think everything is going to turn out fine. But it was really mind-boggling how as a physician, having a network of physicians that were involved in my care, and then having actually written policies inside of insurance companies about what are the types of things we cover, and how do we pay for them, and how do we approve them, that despite knowing all that, it was still really hard. And so I can only imagine, if I had that experience, what does the quote unquote average American, who maybe doesn't have a background in healthcare or has much lower levels of education or healthcare literacy, and doesn't have these connections that they can leverage. And frankly, that's 99.9% of Americans out there. And so it was really, really eye opening. And I was thinking, as one of the the sort of concrete data points that I have from that experience is I have a mountain of letters that I received from my insurance company about status updates and approvals and denials. And it was just kind of mind-boggling that in this era, given how far we've come in terms of just overall technology and AI, that I'm sitting on a massive pile of letters is my way of transacting with the healthcare system.
And I will say that I think that keeping us in the 1970s as far as communication goes with insurance companies and hospitals is not by accident. Because the longer that the services are delayed, the longer it takes for the insurers to have to pay, and the longer they can hang on to our money and make investments on it. And yes, that's a little cynical, but
no, it's that's the reality. I mean, it really is a system of how do we delay and deny care to increase profits and kick the can down the road, and ultimately it's the patients that get holding the bag, and maybe ultimately it's another insurance company when that problem gets pushed into the following year when they have to switch to a different company or plan. And that is the thinking and underlying strategy that goes into a lot of this.
What you were dealing with, and you and I know this term, is called prior authorizations. Can you explain to people what are prior authorization? What were they originally intended to do, and what have they morphed into?
Prior authorization was something that was born out of the managed care era, which basically requires the insurance company to provide approval to doctors if they order particular tests or for particular. It started as hospital stays, but it's really extended to everything under the sun because whether it's an advanced imaging study like MRIs or CTs or drugs, particularly higher cost drugs, they almost all now require prior authorization. And there's a whole separate process that a doctor and a patient need to go through in order to actually get approval to get the care that they need.
I think that we talk about healthcare costs going up. A big piece of that is the administrative burden. And I heard on a podcast today that it's getting to the point that there is one administrative person in every physician's office for every 2 healthcare practitioners. It used to be 1 admin per 10. Mm-hmm. Now it's 1 to 2. And I don't know if I read it from you or another article, but I think someone said like in 2023, there was over 50 million prior authorizations that were sent to physicians' practices or pharmacies or hospitals. Mm-hmm. 80% of them were appealed and overturned. So it makes you wonder, if 80% were appealed and overturned, did we need 50 million that increase that burden and delays care?
Well, a couple things about that I'll probably blow your mind even more than that. One is the 50 million, I believe, was just Medicare Advantage. So when you talk about the commercial insurance industry, I mean, you're talking about orders of magnitude more. So think about hundreds of millions, potentially billions of requests. I haven't done the actual math. And think about the administrative waste that is in terms of our system. And when you were actually talking earlier about, did I encounter scenarios where there were things that I was advocating for in leadership roles, whether it was, we need additional providers or we need a social worker to provide behavioral health support for a provider. Invariably, the reason we couldn't increase our clinical resourcing was because we have this huge administrative overhead to manage all these burdens and processes and red tape. And so that's all waste and inefficiency in terms of the value it's creating for us as a society and for individual people. And so that 50 million number is a good one to think about in terms of what are the what are the consequences for us as a healthcare system. And you also said something that's really important, and it was around the 80% of denials that are overturned. But there's another really important piece to that. So consumers get denials all the time. Only 1% of people usually end up appealing a denial. So that means the insurance company wins 99% of the time. And it's no wonder that they continue to embrace a process that creates so much friction and abrasion because people give up. But when they actually file an appeal, and that's the 80% number, 80% of appeals 80% of denials are overturned on appeal. So it tells us, one, that unfortunately doctors and patients are getting squeezed and giving up, and to no fault of their own. And when they actually go through the process of trying to formally get these decisions overturned, they're right 80 times out of 100. And so I asked myself, where is the accountability to insurance companies that they can be wrong 80% of the time without any consequences?
So everybody, just to kind of bring it to a close, prior authorization basically means when a physician tells a patient or a hospital wants a patient to do something, prior to getting the procedure, you need authorization from the insurer. And, as we just discussed, you're talking hundreds of millions of appeals every year. And the administrative burden is shocking and burning out docs and nurses and office managers. I mean, to me, I was going to ask you, you've been in the carrier world, in the hospital world. I was going to say, is there like a low-hanging fruit, something that we could focus on that if we were able to change it would really make a difference? Would eliminating prior authorization outside of a cup, like put up some guardrails, like you can't ask for prior authorization if it's less than $2,500. Would that make a difference?
Well, I'll give you. I'll start by answering with just some like data points in traditional Medicare and Medicare Advantage, because it's sort of a great natural experiment where you have public insurance program that is the largest in the country, and half of it is administered by the government, and the other half by private insurers. In traditional Medicare, there's only about 50 procedures that require prior authorization, and most of them are the types of things that could be considered cosmetic in nature. So, for example, if an older adult has a droopy eyelid, something called ptosis, there could be a very important reason they need that surgery, but that's the type of thing that is authorized because there's potential for waste and abuse if you don't. Sure. In private Medicare, Medicare Advantage, it varies by insurance company, but there's some data out there that certain for-profit insurers require authorization for somewhere between 3,000 and 5,000 procedures. So we're talking an order of magnitude of 100-fold. When you look at the costs and outcomes of people that get care in those two programs, we're starting to see a lot of evidence that Medicare Advantage or private Medicare actually costs the American taxpayer more, that we overpay for the care compared to traditional Medicare, and the outcomes are equivalent. So I guess that's a long way of saying there are very sensible ways that we could go about attacking this problem. And you brought up a good one. One is, do we start or do a better job looking at the, overall cost of a procedure? I would argue that if you're really worried about the bad actors, people who are abusing the system, and that's sort of a justification that's floated by a lot of insurers and even by government officials, then we should go after those people and focus on them, and not require 100% of clinicians to authorize procedures when it's really 0.2% or 0.1% of the providers or fraudsters out there who are abusing the system. And we do have mechanisms. I mean, there are other industries that are decades deep into really advanced fraud detection and advanced analytics and AI. And I can tell you, from my own experience and colleagues in the industry, health insurers spend way more on administering prior authorization than they do on actually going directly at the issue of fraud, waste, and abuse and trying to attack it. So I think we have our priorities backwards, and I think we use a really frankly BS argument to justify doing this to so many doctors and patients.
I honestly think prior authorization is one of the biggest evils that there is out there. And to your point, Are they really going after fraud, or is it just their excuse to delay care? And
that's right.
I think we know the answer to that from what you just said.
Yeah, that's absolutely right. And I think the other thing I wanted to mention, especially when I hear, you expressing your outrage and frustration, is I think the complete moral outrage that I feel as a clinician, and also just the lack of humanity I feel like in so many of the decisions that are being made. I'm going to give you an example that actually the reason it's top of mind is it happened today. But I got a call from, and I'm not going to say who for privacy reasons, but someone very, very close to me, whose husband was recently provided a diagnosis by his specialist that it was very likely that he had muscular dystrophy. And the doctor ordered a genetic test because there's all different types of muscular dystrophy, and they have very different implications for the progression of the illness and what treatments may be available. And so the test was sent for approval to a very large insurance company. And I heard from this individual today that the authorization was denied, and the justification, according to this individual, and I'm waiting to confirm this with the primary source documentation, was that because there's no treatment that has been established for this particular type of muscular dystrophy, there's no point in testing for it, and we don't need to pay for that. And I mean, it's just shocking that we put fellow human beings in a position like that, where they have no autonomy or control over their own health. God forbid this individual actually wants to be able to sit down with his children and tell them about a disease that runs in the family and what are the implications, as they go out into the world and become parents. And, that doesn't matter to an insurance company. It just means that they saved, in this particular test, I'm guessing $2,000. So it's just, a lot of what I'm doing right now in my work is really trying to learn people's experiences and bring these stories to light, because nobody wants that for anyone in their family or their friends. So there's no reason that we should tolerate it for other people.
So let me tell you the hypocrisy of this. So when I used to, and this is 15 years ago, so when I used to negotiate with carriers, we had expensive drugs coming out. This is when all the big like rheumatoid arthritis drugs were coming out, and the Humiras and Remicades of the world, and you're talking anywhere from $30,000 to $80,000 a year. And they would say literally, you know what? And I was with J&J. you guys, we don't know if this is going to work. It works with 70% of patients, but we don't know that it's going to work. So half the time we're wasting it. If y'all came out with tests that would tell us and give us a better idea, will this procedure work? Will this drug work? That's what we need. That we wouldn't have to do as much prior auth and step therapy if you gave us these tests. Well, over 10 to 12 years, guess what? We invested in it. The physicians, scientists, everybody invested in it. We have this genetic testing. And do you know, in my old role going after legislation, we're fighting insurers to cover the tests that they asked for. And these tests range from $200 to $2,000-3,000. Mm-hmm. Sometimes for procedures that cost $50,000 or drugs that cost $80,000. And it's not just about the cost, but it's about the patient who has an illness that is getting worse. And this test could say, you know what, don't waste your time being on a drug that doesn't work for a month or 2 months and your disease gets worse. We can pinpoint which one you need right now. And they don't want that. They wanted personalized medicine. They have it now. That disrupts their profit mode, and it is infuriating.
That's a great example, and I think at the very core of so much of what is not working in our healthcare system.
You and I were chatting, I think, a couple of days ago, and another thing out there is benefit design, and open enrollment is coming, and so a lot of people, it just boggles their mind that they're like, now wait a minute. Are you telling me that two people in the same city with the same disease, with the same diagnosis could have a completely different experience, albeit with the hospital and the insurance company and all these things? Help people realize that all benefit designs are not the same, all hospitals are not the same, all insurance companies are not the same, et cetera.
Yeah, it's an important question. And what's important to remember is that inside an insurance company, every single health plan, the most important thing, and frankly, one of the only things that they consider is the actuarial value of that plan, which what that means is what is their return on investment from selling that particular plan to a particular individual. And the reason I think that's important for people to know is when they're out there kind of shopping for insurance, they're looking for an insurance plan that is going to create a lot of value for them. And very often the plans are marketed in such a way that they're buying something that is really going to create value for the company that's selling it to them. So it's really important, I think, to be really vigilant and really kind of do your best to understand what you're signing up for. And I think there are a couple areas that I think are really important that a lot of people don't think about until after. And I've been a victim of this myself, even working inside the insurance industry. And it gets at this issue of how can two people same disease, same area, get really different care. One relates to network. And, there's terms like an HMO, a PPO, there's even something called an EPO. And the reason those are important is because some of them are networks where you have access to a lot of doctors, and some of them are networks where it's a very what we call narrow network, and it's a very limited number of providers, and oftentimes it requires a referral to go from one provider to the other. And there's also a difference. I would say to people, don't get falsely reassured that you see a long list of doctors, because there's this real phenomenon that is known as a ghost network. And so there's a long list of people on a piece of paper, but what happens when you go to actually try and make an appointment with those individuals, they're no longer with the insurance company, or they've closed down and they have a full practice, and so they don't see new patients. Or I'll give you an example. For me, it was related to finding a primary care physician. When I shop for a health plan, I wanted to make sure there was a good list of primary care physicians available. And then when it came time to actually book an appointment, I went to my insurance company's website, and although it initially appeared there was a large number of internal medicine physicians that would be able to see me, when I actually went to sign up, the list was much, much smaller than what was originally presented. And that was because included in the directory were all the internal medicine doctors that actually only provide care within the four walls of a hospital. And they're called hospitalists. And they should not be in a provider directory for a consumer, because you have no ability to choose who's your doctor when you go into the hospital. And those are not the type of doctors that I want to see in the clinic for primary care. So the list narrowed from literally hundreds of internists to maybe a half dozen that were available to me. And then a lot of them didn't have appointments or weren't seeing new patients. And so that's just an example of what you sign up for may in fact not be what it seems. And so you really need to do your homework to understand who's actually in that directory and are they seeing patients.
Yeah, that's crazy. I mean, I've heard the term ghost network also, mainly around like psychiatrists, because there's not a ton of them out there. And people sign up to these plans. There's a bunch of psychs, but when they actually call the offices, to your point, they're retired. They're full. They don't have any more spots available. They don't have appointments till a year out. So how can somebody avoid that? Or can they?
Well, I think there are two things. One is just doing your homework before you actually sign up for your insurance plan. Don't make any assumptions that a certain hospital system is going to necessarily be in your network because they were in it last year. The contracts change all the time. And so you really need to do your diligence up front. And, in hindsight, when I saw that big list of internal medicine docs, if I would have actually, practiced making an appointment with some of them, I would have realized that this list isn't accurate, and it would have made me think twice about signing up for that health plan. So one thing is doing the research on the front end. And then on the back end, after you've already signed up, if you're not getting access to a doctor or the type of appointments that you want, one option is obviously to work with your insurance company, because they're required to provide an adequate network of providers. And so they may be able to help you do that. And if not, then you can also escalate the issue to the Department of Insurance or whatever the regulatory body is in your state to see if you can get someone there to help you. And so, you really need to advocate for yourself.
Yeah, that's crazy. And to your point, so the different regulatory bodies, usually, like I say, in Florida, it's the OIR, the Office of Insurance Regulation. And so absolutely patients can reach out, but they shouldn't have to go there. So, and you may have already heard some of these podcasts, Dr. Glickman. Over the summer, I did the Healthcare 101, and in two of them, I had a insurance broker. Mm-hmm. And what I found out in talking to him was their services are free to patients. They're paid by carriers. And so they are really good at telling patients, like if you say, you know what, my doctor is Dr. Smith over on this street. Can you make sure my plan that I'm going to sign up for has that physician? Your agents can really help you. And then the other piece that you can do before you sign up, to your point, doing your homework, is go to your physician's practice and ask them, and to the hospital that you usually go to, say, are you in this plan? Are you going to be in it next year? So to your point, we have to do our homework. It's unfortunate, but we have to do our homework.
Yeah, those are great points. And those are both really good resources to think about as you try and figure out what the best plan is for yourself.
Two more questions for you before we take off. This has been phenomenal. So, what doctors wish patients knew and what patients wish doctors knew. If you could tell patients and physicians one thing that would save them a lot of frustration when they're dealing with insurance companies around prior authorizations and denials, what would that be?
Boy, I wish there was a silver bullet that would just sort of cut through all of the red tape and frustration. I would say, as it relates to both doctors and patients, it's really to work as a team. And I think the best way for patients to navigate that is to really enroll their primary care physician and the practice administrator or people that work at their practice in ensuring that they're communicating really well. Both the doctor and patient are clear on, does something require prior authorization? If so, what is the next step? Who needs to submit what by when? Because there are so many moving parts that I think it's important to really be in lockstep. And I would say beyond, being proactive and really trying to partner and work together is really understanding what is the process and make sure you're really clear about what is required for a given insurance company, a given plan, because there's so much variation in process, even within the same insurance company, based on what specific product or plan you have, that you may not need to jump through certain hoops for certain types of health plans, and you actually may be doing unnecessary work. So I think grounding yourself in what the truth is really, really important as well.
ChatGPT, I think you're well aware of this. The carriers, and maybe even the hospitals, are using AI to deny claims. You can actually use ChatGPT or some of these other AI software programs that are super easy on the internet, not only to fight your denials, but also to fight prior authorizations and to fill them out. And to your point, work with your physician practices. And there's also advocacy organizations out there that can help.
Yeah, those are excellent points. The insurance company is banking on you not appealing a denial, because very few people actually do. It's actually less than 5% of all denials are appealed. But it turns out your chances are really good if you're working with your doctor to get the information to essentially explain why you need that particular medication or treatment. Your chances are about 80% that denial will get overturned. So don't throw your hands and give up, even though it can feel really frustrating. And you're right, they're both advocacy organizations, and also more and more we're seeing AI-driven technology and companies that are really designed to help patients navigate the process, to pre-populate forms and letters that they can use. So don't feel like you have to essentially, do it all from scratch.
Yeah, you know what? I think that for people to know, to your point, and this from an insider's perspective, that their chance is around 80% if they appeal. Don't get frustrated. Just know this is part of the process. And now you got AI and you got physicians practice. So we need to use all our resources and not get frustrated, and just know that this is what we have to do, but it'll work.
Exactly.
So last questions for you, Seth. I know we've been on here for a while, and I really appreciate your insights. I know that you have moved into a consulting role, and I think you recently have your website. What's your website's name?
The website is SethGlickmanAdvisors.com.
Very nice. So in your new role, you're focused on, I believe, working with physicians and other in the community who want to make a difference. The advice, what's the advice that you can give to these advocates, especially physicians that want to drive change, or executives, when their schedules are so busy and they feel like, are they really in a position to influence against these huge organizations? What would be your advice to them?
Yeah, I think there are a couple things. I would say two things. One is really to be an advocate and to speak up, and don't feel like you need to do it yourself. But there are professional organizations and advocacy organizations, both likely within your community and also nationally, that you can be a part of. And so that is like having a bit of wind at your sails when you have a community of individuals that are part of an organization and part of a bigger cause. So that can make a big difference. And then the other thing I would say is whether you're an individual clinician, that there are things that you can do to advocate for your own self and practice. An example would be reaching out to elected officials, for example, especially phone calls or in person whenever possible, to raise concerns that require them to do things on your behalf. I think that's always an effective strategy, and it feels like we actually have some degree of control or autonomy or ownership over problems when we can engage others in helping us. And then I think for physicians too, and this is where a lot of what I'm doing with my practice is focusing on helping physicians grow their leadership skills and growing their impact and influence, either within their practices or within larger organizations. So I'd say that's another way that individuals can really focus on having an impact across a much broader scale as they grow their ability to become better leaders, more influential. They have more authority over different areas, and that can make a big difference as well.
Oh, that's awesome. I appreciate that. I think that's really helpful. And I did hear very interesting, we hear about physician burnout all the time, that actually having a cause and advocating helps to reduce burnout. So, it's almost like you're feeding your soul, fighting the good fight.
That's right. We all need meaning and purpose in our life and our career. And one of the key, I think, missing ingredients that drives a lot of burnout is not having connection to purpose and community beyond all the operational and logistical challenges of what is required to take care of patients. So I think that part is really important.
Well, that's awesome. So, Seth, I just want to wrap up and thank you for your insights today. I really hope everyone appreciates what it took for you to walk away from an industry that you were doing really well at to try and create change in a system that we all know is focused on profits over patients. It's amazing to have someone like yourself who's worked in the belly of the beast and share with us the naked truth so that people can feel emboldened. And you know what? Good luck. And I want to stay connected with your endeavors of, coaching and teaching physicians and executives, around leadership and how they can create change. And for everyone listening, you can go to disruptivedialogue.org and find the show notes for today's episode, as well as the contact information for Dr. Glickman. And lastly, thank you for joining us on Disruptive Dialogue. If you enjoyed this episode, please subscribe, share it with a friend, and leave us a review. And until next time, stay informed and take charge of your health.